Hello, and welcome to the Chest Journal podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Matt Siuba.
Hi, everyone. Welcome to the Chest Journal podcast. My name is Matt Siuba. I'm a medical intensivist at the Cleveland Clinic in Cleveland, Ohio. Today, I have the distinct pleasure of talking to Dr. Eddy Fan and Dr. Stephan von Düring to talk about the recent paper in the journal, The Association Between Mechanical Power Within the First 24 Hours and ICU Mortality in Mechanically Ventilated Adult Patients with Acute Hypoxemic Respiratory Failure, a registry-based cohort study. So first of all, thanks to you both for joining us today. Let's just kind of get a better idea of who you are and where you work. So just basic introductions, and we'll start with Eddy.
Great. Thanks, Matt, and thanks for the invitation to join the podcast. My name is Eddy Fan. I'm an adult intensivist at the University of Toronto in Toronto, Canada, and a member clinician scientist that helps with this paper that we're discussing today.
Thanks, Eddy. Stephan?
Yeah, thank you all very much for this kind invitation. My name is Stephan von Düring. I'm an internist and intensivist, and I'm born and raised in Geneva, Switzerland, where I did my medical training. And I had the chance to come to Toronto between 2020 and 2023, where I did a clinical fellowship. And as I wanted to do or get some formal training in epidemiology, I completed a master's in ClinEpi. And I was very fortunate to have Professor Eddy Fan as my supervisor. And currently I work back home in Geneva as a senior clinical associate in the Division of Critical Care Medicine at Geneva University Hospital.
Fantastic. Thanks to you both for being here. Stephan, we'll stay with you just to get us launched into this topic. So for those that aren't familiar, what is mechanical power when we're talking about mechanical ventilation, and why should we care about it?
So that's a really great and important question. So kind of to contextualize, what we know is mechanical ventilation is a life-saving intervention, and it's particularly important in the management of patients with hypoxemic respiratory failure. However, it can lead to serious complications known as ventilator-induced lung injury, or VILI, which can cause or worsen pre-existing lung injury. And so patients are at a higher risk of prolonged mechanical ventilation and increased risk of mortality. And over the past decade, there's been a lot of research to identify lung parameters that are responsible for the genesis of VILI, and current lung protective ventilation strategies recommend limiting tidal volume and inspiratory pressure. But despite the application of these strategies, we see that mortality remains high. And if we look at ARDS data, we see that it's averaging around 35%. So we really need to do better. Now, ventilators deliver air under pressure to inflate lungs, or more specifically, the respiratory system. And with each breath comes a certain amount of energy to overcome the resistive and elastic forces of the respiratory system. And so this energy transfer may be responsible, or at least contribute to the genesis of VILI. And that's where mechanical power now comes in, because it quantifies this energy transfer over time, expressed in joules per minute, and it corresponds to the area under the dynamic pressure volume curve during the inspiratory phase of a breath. So, and then it's multiplied by the respiratory rate. And in 2016, Gattinoni and colleagues used this, in 2016, Gattinoni and colleagues used the equation of motion to propose a simplified formula to estimate mechanical power from standard ventilator settings. And so they used tidal volume, plateau pressure, peak pressure, flow resistance, and respiratory rate. And so now the concept of mechanical power is a comprehensive metric encompassing key ventilator parameters that are associated with the genesis of VILI.
Thank you so much for that comprehensive answer. That was fantastic. In this particular study, you all used a little variation on mechanical power called dynamic mechanical power. And why is that something that is useful either for clinical care or for research?
Yeah, that's right. That's an important point. The idea is that driving pressure is the distending pressure above PEEP that's required to generate tidal volume. And it's calculated as the difference between plateau pressure, which is the pressure in the respiratory system at the end of inspiration. So it's measured through an end inspiratory pause where the flow is equal to 0. And it's the difference with PEEP. And there's clear evidence to suggest that limiting driving pressure is associated with better patient outcome. Now, the problem is that traditional lung protective ventilation strategies rely on static parameters like plateau pressure, and that requires this inspiratory hold, which is problematic. And what we see is these static measurements are infrequent, they're often limited to sicker patients, and maybe they even underestimate the maximum pressure experienced during dynamic inflation. And so this raises concern about real-world applicability and generalizability of static parameters. And that's where dynamic measurements, such as dynamic driving pressure, circumvent these limitations. So dynamic driving pressure is the difference between peak inspiratory pressure, so measured at the end of inspiration, but before the inspiratory valve closes, and PEEP. And its strength is it really captures real-time distending pressures during each breath, and this is without an inspiratory pause. It can be measured continuously on all ventilated patients and regardless of the ventilator mode, and it facilitates a broader implementation of lung protective strategies in everyday practice. So, and finally, recent data supports the fact that limiting dynamic driving pressure reduces mortality. And so that's the rationale behind why we chose to use dynamic driving pressure in our mechanical power formula.
Great. Thank you so much for that comprehensive answer. And I think that's something that kind of gives us something to think about measuring this pressure in the future. Maybe that's something that our ventilators can do for us. Let's move into talking more about the study. So I'll turn to Eddy now. So what inspired the specific study question? And then once you've defined that, can you give us a basic overview of the study design itself?
Yeah, thanks, Matt. I think Stephan touched on this nicely. I think the challenge has been that despite, decades of research in ARDS, we've become aware that, while mechanical ventilation is necessary, unfortunately, it can also lead to further lung injury, organ failure, and death in many of our patients, and mortality and morbidity from ARDS, or patients with hypoxemic respiratory failure who require mechanical ventilation remains high. And we have a number of trials suggesting that, yes, various forms of mechanical ventilation or how we set the ventilator are very important in contributing or mitigating against this kind of outcome. And of course, now lung protective ventilation with low tidal volumes and low airway pressure, as Stephan mentioned, has become the standard of care. But despite that, many other subsequent trials, like manipulating PEEP, trying different modes of mechanical ventilation, different targets, have really not shown many advances in our understanding or in the management of these patients. And I think, again, we hit on this very important contribution of the many from Professor Gattinoni, who, of course, unfortunately passed away earlier this year, suggesting that maybe if we take some of these variables together rather than studying them in isolation, might be the way to further reduce ventilator-induced lung injury, or VILI. And of course, then further reductions in ventilator-induced lung injury may translate into better or more clinical benefits for our patients. And so that's really what motivated our study, was that, sort of the traditional way of looking at things has been to manipulate one variable, PEEP, tidal volume, airway pressure, this sort of thing, and maybe putting them all together might be a way to do that. So that's really what inspired the study. And of course, before you launch into a big clinical trial, it would be good to use existing data to sort of see what associations we can get from the existing data and sort of provide additional strength for moving forward with, again, further evaluations of interventions targeting this parameter. And then in that vein, what we did was we leveraged a large registry of mechanically ventilated patients that we have here in Toronto. So basically for the last 10 years, a consortium of academic and community hospitals across the Greater Toronto Area have been contributing data to a registry called the Intensive Care Observational Registry Project, or ICOR is what we call it for short. And basically we have standardized uniform data collection every day on every mechanically ventilated patient that gets admitted to these ICUs. And so this has been a powerful resource for us to answer some of these kinds of hypothesis-driven questions, to again provide maybe early insights, pilot data to better understand, something that might be worth studying in a clinical trial, maybe we need to refine some of our understanding of how that intervention might work. We could, again, use the power of novel causal inference methods to get at some estimates of causal effect. But that's basically the overview of the design, is that basically using this registry, we assembled a very large cohort of acute hypoxemic respiratory failure patients, and then we looked at the association between mechanical power on the first day of mechanical ventilation with the outcomes that we were interested in.
Excellent. Thank you for that overview. So speaking of the population itself here, in this study, the population is defined as having acute hypoxemic respiratory failure. With the, sort of recent expansion of the definition of acute respiratory distress syndrome, I kind of wonder how different or how similar do you think these patients are to patients with ARDS? And I'll turn back to Stephan for this question.
So thank you. That's an important question, so that we can compare our results with other studies. I think what's important to remember is that most research exploring lung protective ventilation strategies has focused really specifically on patients with ARDS. And this includes studies that have explored the association between mechanical power and patient outcome. Now, the problem with ARDS is that it's really challenging as far as the diagnosis. We know that up to 40% of patients who meet its criteria are not even diagnosed with ARDS. And if we follow the guidelines, these patients are probably not even eligible to strategies that have been developed for ARDS patients. However, in recent years, there's increasing data that has shown that risk factors associated with the development of villi that have been observed in ARDS patients are also applicable to patients with acute hypoxemic respiratory failure. And I think this is a really important point. Now, acute hypoxemic respiratory failure currently has no universal definition. And so we really chose a pragmatic definition based on PF ratio less or equal than 300 millimeters of mercury, or an SF ratio less or equal to 315, which align with current definition of ARDS. And this and these patients in our study represent perhaps a broader population of acute respiratory failure. Not all meet traditional ARDS criteria, but I think they probably resemble closer to the actual patients that we treat in our ICU and to whom we finally apply these lung protective ventilation strategies. So that's why it really made a lot of sense to apply this study on the broader group of patients with acute hypoxemic respiratory failure, which finally probably don't differ that much to the ARDS definition patients.
Thanks. That kind of confirms some of my thoughts about this, but it's nice to have a better handle on sort of the population that we're talking about. So now that we've defined the population, the parameter of interest, and sort of talked about the basic study design, I just want to take a minute and sort of highlight some aspects of the statistical analysis plan here. There's some really thoughtful analysis that went into the construction of this paper and the questions that I tried to answer. So, Stephan, could you tell me, is there anything in particular that you're proud of in the statistical analysis plan for this work? I mean, there's so many things that could be highlighted, but I'll let you take it from here.
So thank you very much. Yeah, there's a lot in this study, and we were really fortunate to have Quan Liu, who's the second author in this manuscript, to help us with the statistical plan and the analysis. There are a couple key points I find that were really interesting. The primary objective here was the association between high mechanical power and ICU mortality. And what you'd really want to do is an RCT to explore the causal relationship. Now, since this is retrospective data, we thought, all right, let's try to handle this like an intervention through a propensity score-based inverse probability of treatment weighting approach between groups. So because there's no randomization, treatment assignment, so here to high mechanical power, may be confounded. And for example, patients receiving high mechanical power may be sicker, have a higher SOFA score, or worse PF ratio. And so what we did is we calculated the probability of receiving the intervention. So again, here, high mechanical power, given the observed covariates. So, for example, our SOFA score or our PF ratio, and that was our propensity score. And so the propensity score depends on the covariates that are put into our model. Then inverse probability treatment weighting uses the propensity score to create a weighted pseudopopulation where the treatment assignment, again, high mechanical power in our example here, is independent of measured confounders. And that kind of brings us like to an RCT because confounders are then balanced across treatment groups. So inverse probability of treatment weighting restores exchangeability between our treatment groups. And we're then kind of truly looking at the association between mechanical power and ICU mortality. And we thought that was really a good application of this statistical tool. And it allowed us to retain the full sample and to estimate the average treatment effect of mechanical power and ICU mortality. Now, propensity scores can only adjust for observed confounders that are put in our model. And this was a concern for us, that there might have been some unmeasured confounders that could bias our estimates. So what we did is we estimated the propensity score using a lot of clinically relevant covariates that we thought were rational and were associated with mechanical power. And then we conducted several sensitivity analysis, and which means that we really worked in recalculating or remodeling this association to make sure that we always got the same results. And finally, we did an e-value calculation, which estimates how strong would an unmeasured confounder need to be, both with the exposure and the outcome, to fully explain away the observed effect. And with this, we thought that we had a really clever plan. Another point was, in our secondary objective, is that we wanted to kind of do a deep dive into exploring the mechanical power threshold below which we would reduce ICU mortality. So the rationale behind this is that multiple studies have defined a mechanical power threshold, but they use the median mechanical power of their cohort. And surprisingly, there's no reproductive threshold that has been identified. And it was curious for us to investigate if there was perhaps a nonlinear association between mechanical power and ICU mortality. So what we did here is we ran a standard logistic regression with a linear specified relationship, and we compared it to a logistic regression with a restricted cubic spline. And then using the best fit model, we applied a change point regression analysis to identify a mechanical power level that would be associated with a significant change in ICU mortality. And that was really important because we wanted to have the best model of this association. And what we saw is that it was a nonlinear relationship between mechanical power and ICU mortality. And then, as you can see in the supplementary, we also tried to mimic the SERPA-NATO analysis by dividing our cohort into 10 groups or deciles of mechanical power. And this was to identify a cutoff point at which the odds ratio of ICU mortality changed compared to the overall median of the cohort. And again, this was to try to manipulate the data in another way and see if we always got consistent results. I want to say that finally, what was important is that we needed to make sure that high mechanical power was not simply driven by severity of lung injury. And so what we did is we looked at the association between high mechanical power and ICU mortality, and this time stratified the severity of lung injury. So we stratified it by PF ratio categories, ventilation ratio, which is basically an index of dead space ventilation, and respiratory system elastance. And it was reassuring to see that severity of lung injury did not modify the association between high mechanical power and ICU mortality.
Great. Thank you for that overview. You really touched on all the points of the statistical analysis plan that I really appreciate. And as somebody that's really physiology minded, I'm really excited about the fact that we consider nonlinear relationships and some of these physiologic parameters, because obviously physiology doesn't usually follow a straight line or a dichotomous association. So thank you for taking us through that. That was like a very nice plain language summary of the methods. You alluded to some of the takeaways from what the analysis gave us, but what's your plain language summary for what are the key takeaways for this work?
Yeah, so I want to say that there's kind of two key takeaways. The first one, I think, is in adult patients with acute hypoxemic respiratory failure, I think it's pretty clear that high mechanical power at the onset of invasive mechanical ventilation is associated with higher ICU mortality. And acute hypoxemic respiratory failure is beyond the scope of ARDS. So this is really applicable to the majority of patients that we treat with invasive mechanical ventilation. And this also suggests that clinicians should consider limiting mechanical power early to mitigate the risk of VILI. And I think the second key message is, despite using different data-driven methods, we found no consistent safe mechanical power threshold, which means that mechanical power operates as a continuous risk factor where higher mechanical power is associated with worse outcomes.
Thank you so much. So, Ed, you started to give us some ideas of how clinicians should start to think about mechanical power in their clinical practice. How would you, if somebody asked you after reading this paper, how can I attend to mechanical power in a way where I can, maybe perceive the differences that I may be affecting by changing the ventilator settings? What would you tell them?
Yeah, so this is really an important question, is basically how do we use mechanical power at the bedside? And I think one question is for what patient? And our results here kind of show that we should consider mechanical power for all patients on invasive mechanical ventilation, regardless of the reason. And the rationale is that mechanical power encompasses all ventilator parameters that are thought to be associated with the genesis of VILI. So this makes sense. Then when? Well, our data suggests as soon as the patient's basically put on the vent. Now, the question that follows is how to calculate it, and should we use dynamic driving pressure? And so until ventilator manufacturers implement mechanical power measurements using the dynamic pressure volume loops, clinicians are going to have to estimate it manually. And there are several validated formulas that exist with different versions for pressure control or volume control. But I think that using dynamic driving pressure to calculate mechanical power allows for a consistent estimation across modes. Now, one point that we need to touch base on are the limitations of its application at the bedside. And right now, there are some important limitations before its implementation. And I think that we need to clarify that there are no reference range. So we don't know what normal mechanical power is, and we only know that higher mechanical power likely increases the risk of worse outcomes. We have no validated threshold for VILI onset. There's no clear guidelines on how to reduce mechanical power effectively. And there's no prospective trial that has yet shown that lowering mechanical power improves outcome. So I think the bottom line is that mechanical power isn't really bedside ready just yet, but I think it's a powerful concept that reframes how we think about the genesis of VILI.
Yeah, thank you for that summary. That's very helpful. It's nice to hear sort of the how we can start to incorporate this thinking at the bedside. And I at least, personally try to think about the two components of it in terms of the driving pressure and the respiratory rate as I'm setting the ventilator on patients with respiratory failure. But I agree with you, like conceptually it can become difficult for us to know how to actually implement this. So with that in mind, Eddy, if, knowing what we know now about mechanical power, both from your work and the work of others, if you could design the ideal trial to study mechanical power as a therapeutic target, what would that look like?
Yeah, thanks for the question, Matt. I think it's actually, as Stephan alluded to, kind of tricky at this moment. So first is that certainly there seems to be increasing evidence or data that suggests that there is a causal relationship between higher mechanical power and worse outcomes. So that's important, because if mechanical power or higher mechanical power was just a marker of severity, then intervening on it may not lead to any benefits for patients. And I think actually, just as you mentioned, Matt, I think since two of the key components of mechanical power are driving pressure and respiratory rate, and in fact, we have a very nice study from Eduardo Costa suggesting that, maybe driving pressure is 4 times more important than respiratory rate as the main components that we might manipulate on the ventilator for a trial that, any intervention that looks at reducing mechanical power probably needs to focus on reducing driving pressure and, if possible, also reducing respiratory rate. And that, again, in that any such intervention, it seems that reducing driving pressure might give you more bang for your buck than reducing respiratory rate. And we have lots of animal data, again, suggesting that, it's not really clear, like which levers of the mechanical power equation should we pull. So there's tidal volume, there's pressure, there's PEEP, there's respiratory rate. So again, I think maybe focusing on driving pressure seems to be key, and then respiratory rate after that. But we don't really know, as Stephan alluded to again, that there are any specific safe thresholds for any of these various parts of the mechanical power equation that we should be focusing on. And so, there's animal data, at least, that shows that at the same mechanical power, even if you're ventilating with higher tidal volumes or higher respiratory rates or higher levels of PEEP, that at the same mechanical power, it led histologically to the same degree of lung injury or damage when they looked microscopically. So I think there's still some work to be done to refine the intervention, to understand how we might manipulate mechanical power in such a trial. And once we have that information in place, then of course it would be prudent to conduct a pilot study. So before, again, launching into a very large trial, which will have challenges with resources, timing, feasibility, it would be good to understand that introducing such an intervention targeting mechanical power would be feasible and safe in a pilot study before moving on to a larger efficacy study. But again, in the interim, I think the good news is that there is work around the world currently focusing on reducing driving pressure, which again seems to be a very substantial component of the mechanical power story. And so certainly as these trials come to fruition, we might find that if a strategy that limits driving pressure is beneficial, then again, perhaps there might be even more benefits if we move on to a trial looking at interventions targeting lower mechanical power. Conversely, if these trials looking at limiting driving pressure don't seem to lead to many additional benefits, then it actually may give us pause about thinking about moving forward with a trial targeting mechanical power.
Thank you for that overview. That's a great summary of where we are and where we might go. And I'm just kind of stuck on the idea of the mechanical power and the animal study you mentioned with mechanical power, even under different settings to generate the same power, having the same histologic change. I'm going to be thinking about that for a while. I'm really going to be thinking about your paper too. I really appreciate you sharing your work with the journal, and I appreciate both of you for joining me today for this podcast. So thanks so much for your time, and we'll see everyone next time.